What is going on, guys? Welcome back to another video. Today we're going over the bad and bloody portion of the good, bad, and bloody clinical rotation series focused today on emergency medicine. And again, it's my own personal beliefs and does not reflect my institution or the hospital belief, anything like that. Just going over my experiences, just how I perceive things, and just to give you guys a little bit more details and insight on what emergency medicine is like. Thank you guys for getting that last video to 100 likes. Let's try to get this video to 200 likes. It really does show me that you guys are supporting the channel and really helping me in terms of this YouTube channel and helping me grow. I'm really excited to continue to make videos for you guys. And a few of you guys were giving me for flexing my AirPods. I did have the AirPods before this whole meme community went off about it being like a luxury, things like that. And I didn't really do it to like stun, I just liked it because it was Bluetooth and I really like the Apple headphones. They fit really nicely in my ears. So that's that. All right, so let's get into the bad and bloody portion of the emergency medicine clinical rotation. I know this is kind of the more juicy aspect of what you guys want to hear in these videos. I messed up again in the first video. I called it the good, bad, and ugly clinical series. And I don't really want to paint the picture of it being ugly, so I changed that to being bloody. And the bad and bloody is going to be kind of the things that I wish the rotation could have been better on, or things just that I noticed that I didn't really like. Like I mentioned in my earlier video, if you haven't watched that, I'll leave a link in the description and you can also click right here, I believe. I mentioned that the hospital I was at was broken into different departments. There was trauma, there's fast track, there's the main ED. And something that I really didn't like about the main ED was that there was way too many residents. As a PA student, it was hard because there were so many residents that I kind of fell back into the shadows a little bit when I was in the main ED. Obviously, I had to step up and work with the residents and do my best to be proactive. And I think I was fairly proactive. Some days, it was so busy that I actually didn't get to see patients on my own. I got to see the patients with the residents together as a whole, and doing the medical history together, the exam together. And again, I know it's a teaching hospital, so that's kind of what you get with a teaching hospital. There's gonna be a lot of residents. There's gonna be much more students than you'd expect. Again, there were a lot of residents, but I have nothing against the residents because they were actually really, really helpful in helping me learn and teaching me different things about the ED. So I'm really thankful for them. But in the sense of being a PA or a PA student in the emergency department, and seeing patients individually, that's where I kind of feel like I lacked a little bit of that independence because there were so many other students that needed to do procedures and see patients on their own as well. And going off the idea that this hospital was broken down into different departments, this hospital, this ER, actually had its own pediatrics section and wing. So there was its own trauma pediatrics and pediatrics ER, ED, that was separate from the main ED, separate from trauma and fast track. So I actually saw a total of 2 pediatric patients during my whole time in the ER, which is crazy, right? If you're at a regular ED, there's no discrimination between peds and adult, but at this hospital specifically, because it's a very big one and it's a teaching hospital, it's broken down into a pediatric wing and then adult wing. So the trauma and the actual ER for kids is separate from the main one for adults. So something I wish I could have done is maybe a few shifts in the pediatric trauma department or the pediatric ED department. At this specific hospital, I know they don't take a lot of, or they don't really take PA or NP students in the pediatrics department, which I think they're trying to work on, but for now it's just residents, I believe. So I didn't get to see a lot of kids during my ER rotation, and that's something I wish I got to do. Another thing that, someone might consider a negative is doing overnight shifts. I think it's not just specific to my hospital, but just as a whole in terms of my program. I think we have to do at least 1 week of overnight shifts. And so I had 4 shifts during my 3rd week where I was working 7 p.m. to 5 a.m. Some people consider that a negative. I didn't really think it was too bad. Obviously getting home at like 5:36 and then trying to fall asleep was a little difficult, but as long as you kind of preface the few days before by sleeping later and waking up later, you should be okay. Another thing, due to the fast pace of this emergency department, I would say that some of the attending physicians were kind of more focused on, getting patients in and out, as they should be. And so due to the high fast pace, some of the preceptors were more focused on, obviously just getting the reports written, getting the SOAP notes done, and it was a little bit less focused on teaching and more so focused on providing medical care, because that is the #1 priority. And that's something that is understandable because the ED I was at was busy 24/7, the main ED was. But on the days where it was just super busy, it was hard to, teach because you want to get patients in and out. There's a lot of sick patients. And I would say one of the toughest or most exhausting aspect of being in the ED or being a PA student in the ED was the number of drug-seeking patients and the mental health patients that came in that had some association with drug use and drug abuse as well. So I think that's very, very pertinent and very specific to Las Vegas, the area that I'm in, but also to other areas as well, because the opioid epidemic is not just in one location, it's obviously all over the country. I would see patients every single day that were essentially drug seeking. And people come in complaining of these pains that they can't really describe, and it makes it tough because you have to draw the line between figuring out, is this patient drug seeking? Is their pain real? And things like that. So you kind of have to be an investigator, and you have to look into their record, or their medical record, and look at their past visits. And especially in Nevada, they've actually harped and made it really hard, not really hard, but a little bit harder to prescribe narcotics. So there's a lot of different processes that you have to do. You have to have the patient sign a lot of paperwork. You have to look them up in the narcotic website, make sure that they haven't received, a large amount or, a recent dose of narcotics or opioids, things like that. The process has become a little bit more difficult in terms of prescribing narcotics, and it's even evident in the providers in that they are more hesitant to prescribe narcotics and opioids. I actually just got an email from AAPA that they think that the opioid crisis is expected to worsen by 2025, and that the number has steadily increased every single year. And it's so tough as a provider because, you have these patients that are either in chronic pain or even acute pain, but because of the drug-seeking patients that are faking it just to get a high or just to get a prescription to get high, it makes it so much harder for the actual patients that need it to get the pain medication they need. And that's kind of a dilemma that obviously healthcare is going through right now, is the opioid epidemic. And being a PA student here in Las Vegas, in the ER, it was very evident. And some people are very convincing. I would go in to see a patient and, get a full history, do a physical exam, and then present to the PA or doctor. And, I'll be like, yeah, I think they really need pain medications. And then the provider would show me their record of them coming in for the same problem, things like that, and getting prescribed narcotics. And so it is really tough. It was really exhausting in the sense that once you start to recognize it, it's just kind of saddening to see. And also, it's tough because patients are in the waiting room for a few hours and they want to leave with something. They want to leave with some type of prescription, some type of medication, some type of antibiotic, some type of cure for their problem. Even if you know that medically they don't really need anything, whether they have like a cold, like a severe cold or something like that, where most of the things are supportive, patients expect to leave the hospital with something, most likely a prescription. And it's becoming controversial in the sense that providers are starting to prescribe, more antibiotics, more narcotics, things like that, when they don't necessarily need to. And I think that's leading to a little bit more antibiotic resistance in the community. And it's, again, a dilemma because, the provider, do they want to be stern and risk lowering their patient satisfaction score? Or do they just want to prescribe, a week's worth of antibiotics and make the patient happy, even though they don't really need it, just to make the patient happy? And so that's another controversy, another dilemma that's going on in medicine. But it was definitely an eye-opening experience being in the ER, and I did overall enjoy my experience. I loved that I was able to do a lot with my hands and got to see a large sheer volume of patients. I think that there is a lot to improve on in terms of medicine as a whole, and the providers and the EDs are at the front line of a lot of things that are going on in healthcare. If you made it this far in the video, please go ahead and give this video a thumbs up. I really appreciate you. Today's Spanish words, we're gonna do a couple actually. So last video that we did, part 1, we had the word as, what was it again? Dolor. Dolor, which means pain. And today the word is gonna be enfermo, which is sick. And then also cough. Cough is tos. So cough, tos, and being sick or sick is enfermo. Hopefully you guys like this video. Thanks for letting me, do what I do and supporting my journey. I have, let's see here, I have 9 months until I graduate PA school. I'm super excited. I'm currently on my psych rotation, so I'll be documenting that. Hopefully I can do a day in the life. Obviously I can't show patients, but hopefully I can take you guys with me and give you guys a little insight on what a PA student's life is like in the psych department. Thank you guys for watching. Don't forget to be like my blood type, be positive. I'll see you guys in the next one.